measure weight and waist circumference to determine if they're obese. The NHS, which is the national healthcare system in the UK, is actually instructing family doctors to make sure that on an annual basis, they not just ask, but actually measure the height, weight, and waist circumference of their patients to determine if they're obese. The reason for this is so that they can address obesity, which is now very prevalent in the UK, with 6 out of 10 UK citizens actually being overweight or obese. And as a result of this, they're worried about the increase in the potential obesity-related diseases, such as heart disease, diabetes, and other complications like high blood pressure. So the thing that they're telling their doctors to do is be very respectful when they ask, but they are making them find out exactly what whether or not these patients are in a high-risk category. Should we? Hello, and welcome early by 1 minute to Fertility Fact or Fiction. I am your host, double board certified reproductive endocrinology and infertility specialist, Dr. Rahi Victory, and I am on with my esteemed colleague, Dr. in quotations, because he doesn't actually have a medical degree, Tariq Ibrahim from Ibrahim Strategies Group. And we are going to present you guys tonight with questions and answers and have some information for you. I do want to say that we will next week have Endo Fertility Nutrition on with us. I'm very excited to have her on. She is amazing with the information that she provides and her patients. So very, very cool. Super exciting. And the following week, on the 15th, we will have Jeremy Gruncho from Juniper Genomics with us, who is going to talk about whole genome sequencing. And for those of you that are not familiar with whole genome sequencing, this is where we can actually look at every single gene in an embryo and help us determine why euploid embryos are either not implanting or miscarrying. Something that has never been available before, something that is entirely new and is really the next frontier in genetic testing, making the whole idea of PGT way, way more valuable than it ever possibly could have been before. So we're very excited to have him on, super excited to have Cindy on from Endo Nutrition Fertility, and we will have some great talks. And I'm trying to work on getting a NAPRO doctor on with us the week after. And if you, of course, have any suggestions, please let us know. I'll be reaching out to Dr. Amy, the Egg Whisperer, as well. Hopefully she'll join us soon also. So I don't specifically want to review articles this week just because nothing great was out, but there were two that were worthy of mention that I think everybody should know about. One's IVF, one is IUI. So we frequently get asked, do I need a minimum amount of estrogen if I'm doing a natural cycle or modified natural cycle, FET? Because with our protocol, especially for endometriosis, we're trying to use no estrogen. And even with our normal protocol, we're only giving people letrozole typically, and we try and avoid the estrogen. We only use it when we need it. So with that in mind, researchers have actually looked at over 11,000 embryo transfers and divided the patients into quartiles for their estradiol levels at the time when they were doing the transfer, and then analyzed it to see if there was any difference in outcome. Now, important fact about this study, they actually had really low live birth rates, only about 36, 38%, but reasonable for most countries out there, not quite as high as what we get, but reasonable for most countries out there, and certainly respectable based on big data sets like this with that many people in it. So in that research study, they actually showed that there is no difference between any of the groups. So whether you're in the lowest group or you're in the highest group or any of the ones in between, the outcomes were all completely the same. They had no difference, no statistically significant difference in the live birth outcomes, no matter how low or high your estrogen level was, which proves something that we've been saying for a long time, which is your estrogen level doesn't matter. So a lot of doctors are saying, oh, you can't do Dr. Victory's protocol because there's not any estrogen. Now, that's just blatantly not true. We knew ahead of time that wasn't true because your body is producing some estrogen. And what's present locally in the uterus at the time of the transfer is very different from what you're measuring in someone's bloodstream. Same thing for progesterone. So the reality is that you don't need to take estrogen for an embryo transfer. As long as you're getting your lining to be thick enough, there's enough functional estrogen there to be doing the job. The other study is a study that was just recently published online in Fertility and Sterility, actually from my colleagues in London, Ontario at the University of Western Ontario. They now have a clinic called the Omega Clinic. Great shout out to them. One of my very dear friends is there, Bassem Abu Rafea, great doctor, great guy. And they actually analyzed about 700 patients who were doing IUI with letrozole, specifically with letrozole, and then evaluated what the pregnancy rates were based on the follicle size at the time of trigger. So traditionally with IVF, we're targeting like 18 millimeters. But what they actually demonstrated, which was super, super cool, was that it's actually at 22 millimeters that you get a big increase in success. And that increase was quite significant because their low levels were about 8% when you were getting the smaller than 17 millimeter follicles, but it got up to over 18% when you had a 22 millimeter follicle, and then dropped again once it was past 24 millimeters. So it looks like the sweet spot in those letrozole cycles, so this would really apply to a lot of our PCOS patients, is in and around that 22 millimeter spot. It's not a huge study, but it's a respectable study. They had good statistics and a good analytical system. So I think we might experiment with that and try it again. We actually used to trigger a little bit later, around 20 millimeters, and then we weren't getting quite the results we wanted with our IUI, so we dropped it down to closer to our IVF levels, and we've been happy, but we never quite shot up all the way up to the 22 millimeter level. So maybe it's time that we do that, because 18% with letrozole is actually a very respectable number, because typically we tell patients with letrozole they're only going to score somewhere between 10 to 15%. So this might give us a way better chance of success than what we were experiencing before. So very interesting data, certainly worth retesting and reevaluating. Some other exciting news is that we are almost finally ready to start our new program for older patients, patients with diminished ovarian reserve, where we will be doing a special protocol for them for a very, very, very low cost. And it's only going to be $4,995 for your egg retrieval and embryo creation. And we will be able to do it with no medication. This is up and coming. We will be ready later this month. So if you are interested, please start contacting the office now, because we will be taking names and getting people ready to do consults and then bring you in for the retrievals. The retrieval is the same process, but you don't need any medications whatsoever. So it is way, way cheaper. And for women with DOR or older age, this may be a breakthrough as far as the chances of success. So we're running it as a research protocol, but we are very, very excited about this, because this could change the face of IVF forever. So if you are interested, you're watching the show, you've had failures, you've had some disaster cycles, that kind of thing, please let us know. The only other thing I will say is I had a lovely chat with a lady from overseas who had horrible endometriosis and was talking about doing another cycle, and had already had very brutal surgeries done multiple times. So my heart completely goes out to her. And I wanted to say that this may be a great option for people like that, who are already suffering from endometriosis, don't necessarily want to have to stimulate the endo in any way, but still want to get eggs out, and multiple eggs out instead of just one or two. So this may be doable for them, especially if they don't have active endometriomas present, because we may be able to get really great results from them. So super excited about that. I will also share really briefly one thing that I heard yesterday in conversation with a couple, which was they had done 15, that is 1-5, as of today, actually, 15 rounds of IVF. And I was just flabbergasted that they had been put through that. And so it's very interesting to see different cultures and different countries and how they address IVF, because here I think everyone would consider it unethical to be doing 15 rounds of IVF on somebody. But in other countries, it's considered the norm. And I don't know how they afford it. I don't know how their bodies go through it. I don't even know mentally how people do that. I certainly don't think I could do that to any of my patients, but it's very fascinating to see that the IVF world functions very differently from country to country. And there's actually like independent IVF cultures in each culture, which ties into when you offer donor eggs, when you offer surrogacy, when you do additional testing. I actually feel very strongly that that's the wrong way to do it. It should actually be based on a reasonable expectation of success within a certain number of cycles per age group. But 15 cycles, that's something for sure. Like I was just shocked that they had done that. They actually did their 15th retrieval today. So I wish them all the best. I hope it works out for them, but we were tweaking their cycle to get them better results, because they weren't getting the best care in each cycle that they could. And there are ways for us to improve that for you. Even if you're not doing your IVF with us, we help literally thousands of people every year do their IVF cycles elsewhere, but improve what they were doing compared to what they were doing before. So with that, we'll take some questions.
One important question is, where are you located?
So we have 4 locations now, soon to be many more. So we have Windsor, we have Sarnia, we have St. Catharines, and very shortly we will also have Woodstock. And then we will be opening up in the UK and hopefully very soon in Ireland as well. And we're working on 2 or 3 other locations simultaneously, but I have to keep those under wraps for various business and privacy reasons. But very, very exciting times as we grow rapidly and expand. Super happy about the fact that we're able to take what I think is a really genuine message of let's help people and let's not make it about the money or the various treatments that we do. Let's offer people options and education. And so it's really starting to resonate. And I think the message is getting out there that you can get good fertility care without having to go through 100 rounds of IVF and multiple cycles and multiple treatments.
Hey, Dr. V and Mr. T.
That's you. Yeah.
My A1C is 5.4 and fasted insulin is 120. Would you recommend metformin? My doctor said that it's not necessary. Could this be the cause of multiple miscarriages?
No, certainly not. I would be looking at your immune system, your microbiome, the shape of your uterus, your partner's sperm DNA fragmentation index, the sperm quality, your body mass index, your social habits, your partner's social habits. There's a million things to look at, but not metformin. No, for sure. It's not that smidgen of hemoglobin A1C. That's not even abnormal. Or your fasting insulin levels. So no, I would not be looking at those as factors contributing to your multiple miscarriages.
So here's a question I deliberated on asking, not asking.
Okay.
Hello, Dr. Victory. What happened to me? I'm reading this thing. So anyway, I'm going to ask it.
It is what it is.
It is what it is, yeah. On my AFC ultrasound today, they saw 2 small complex cysts, 1 to 2 centimeters on each ovary. I've never had such cysts before, but did a luteal stim last month. Should I be concerned? Also, do you offer endomapping ultrasounds at your clinic or know where we can get one in the US, ideally in California?
I don't know where you can get them done in the US at all. I know of a place near Toronto that does them. Matthew Leonardi's team does it. It's called Sugo, SUGO. I'm not a believer in them, to be honest. When you look at the data on it, it shows that the sensitivity and specificity is only modest for detecting endometriosis, and it can only detect deep infiltrating endo. You can't pick up superficial endo. So with that in mind, it's really hard to justify because mild endo still has the same impact that deep infiltrating endo does. And so, I'm not helping patients by doing that because I'm not picking up subtle endometriosis. I'm only picking up obvious endometriosis. So I'm not a believer in those ultrasounds at all. What was the first half of the question again?
My AFC ultrasound today.
Oh, yeah, the complex cyst. So I'd have to look at your ultrasound. I mean, if it's left over from a luteal phase that you just did, which you mentioned, those are probably just what we call leftovers. So those are the follicles they aspirated. So yeah, I wouldn't worry about that too much. I mean, obviously always follow the cysts, but it shouldn't impact your cycle.
Well, hey, Dr. T and assistant Dr. V.
Oh,
full 360 on this one.
We took it there. Ouch.
I'm not sure what they're thinking. Guys,
wow.
He's still the doctor.
Wow.
Gotta respect the man here.
I'm leaving.
But your question will always be answered if it's formed in that way. Sure. I cannot stop it. What is rescue IVF success rates in your lab for GV immature eggs, 34 years old?
So we don't do rescue IVM because the results of rescue IVM are very poor, at least not for GVs. We're about to start just to see what happens with the new protocol we have, but GV to mature like M2 follicle rates, and then subsequent blastulation is very, very poor if you look at the literature. We're going to try it, but that's not what we're looking at doing with our new protocol. Our new protocol is getting GV eggs and turning them into M2s, but we're not doing it after stimulation. We're actually doing it without stimulation. So it'll be fascinating to see if it works. We are very hopeful that it will work, but this is a new protocol. Rescue IVM has very poor success rates, so we will be doing it, but I'm not sure how well it'll work. We do routinely mature M1s into M2s, or at least try to. I don't find the success rates are great, even when we do get for like the maturity, and then we fertilize them and they fertilize normally. They don't always turn into great blastocysts. So I think that that's a different system involved there compared to the norm.
I'm curious. Says the questionnaire.
Yeah.
If you can offer any advice, I'm between 20 to 30 pounds overweight and having a tough time moving the needle. I eat really clean and move my body just about every day. However, I have Hashimoto's recently and had iron infusions that impacted my energy levels. I am on, these words for medication sometimes it's just like who can read this stuff?
Escitalopram.
Escitalopram.
Yeah.
Whatever. Which definitely didn't help my already stubborn metabolism. As well, I am nursing an injury due to a disc bulge annular tear. I don't see you until the end of May. Any suggestions I can do in the meantime?
Swim. Swim. It takes all the pressure off your spine, so you don't need to worry about your annular tear. Make sure that you're in relatively cold water, because that makes you burn calories by itself and will actually be really good for your back. So you'll strengthen your back muscles, which is great. You will have no strain on your back, which is great. You will burn a ton of calories, which is what you want to do. And you will build a lot of muscle. So go swimming every day. Don't go to the gym. Don't go for a walk. Just jump in the pool. Well, maybe don't jump in if you've got an annular tear, but go in slowly and swim. The swimming is the trick for you.
Walking.
In the pool?
Yeah, walk in the pool.
You can walk in the pool as well. Tarek's saying walk. Yeah,
no, instead of jumping in.
Walk in.
Yeah.
You can actually walk in the pool. Walking in a pool is very good for building your muscles because it's like, you're fighting the water, right? So, yeah.
I also recommend juicing. Vegetable juice, just to make that clear. That's a good move. Juice is good. Hi, Dr. VNT. I had a miscarriage recently at 13 weeks.
Oh, sorry.
I saved a fetus in uterine tissue. Was wondering if it can be tested or diagnosed for reasons of miscarriage. It's a great question.
It can. You can check it for genetics. They can check it with whole genome sequencing or exome sequencing. You could, if you saved it, you wouldn't be able to check it for infections, but they can definitely do the genetic type stuff on it. I'm so sorry you went through that. That's awful.
Is it not better to test what's going on inside of her now, like doing a test like that, or is it better to actually test?
So she'd be great for microbiome testing, immune testing, stuff like that, shape of the uterus testing, sure. But I wouldn't necessarily feel that she should, be looking for answers from the fetus immediately. It's more likely going to be something related to her. 13-week losses, it could be the fetus, but it's often like a maternal infection or something like that. Yeah.
What's your opinion of an immune protocol FET, specifically prednisone?
Well, prednisone alone by itself has been shown to be useless. So it's not an immune protocol. It's a waste of time. Prednisone in conjunction with other treatments like intralipids or Plaquenil or, other things that we use, tacrolimus and so on, has actually been shown to be beneficial. So in combination, the combination protocols work, but the individual protocol of just giving steroids, that's not an immune protocol. That's a joke.
What's the best diet when trying to do an embryo transfer?
Well, if you look overall at the literature, any clean, sort of vegetable heavy, carb and fat low diet is going to be beneficial. But overall, the one that appears to be the best is the Mediterranean diet. So epidemiological studies of the Mediterranean diet appear to support a benefit in outcomes when people adhere to that diet.
Going to Instagram. Our good friends in Instagram.
Yeah. Instagram's been growing like crazy.
We
Thank
love
you to all of
Instagram.
us,
Absolutely.
all of you who follow us on Instagram. It's very cool.
Are estrogen patches less irritating than pills for priming if endo is suspected, not confirmed? What is the minimal dose of estrogen to still get some priming benefits?
If you have endometriosis, priming with estrogen makes absolutely no sense. Number one, you're inflaming your endo when you want it to be least, loud, least active. You want it to be most quiet. So, giving yourself estrogen in order to line up your eggs with endo is actually completely bonkers. It makes no sense whatsoever. So please don't do that. That's number one. Number two, studies show that estrogen priming is useless. There are now two randomized controlled trials showing that there's no benefit to doing estrogen priming. So on both accounts, don't do estrogen priming. It makes no sense whatsoever.
Do you ever use rapamycin before egg retrieval for someone who has a history of endo and trouble getting blasts?
So we reviewed a study several months ago. I don't even remember how long ago. It was maybe even more than several months ago, maybe a year ago, where we looked at rapamycin use in patients with endo prior to their egg retrieval, and it very clearly had a huge improvement in the success rates. I don't do it because that study was actually looking at live birth as their outcome metric. And so they were doing it from fresh embryo transfers as well as frozen. And so that isn't something we do very much of because we don't do a lot of fresh embryo transfers, especially in an endo patient. It makes zero sense. But the rapamycin did help in both categories. So we definitely use it as part of our frozen embryo transfer protocol. I don't use it that often for STIM, but I'm certainly willing to try, and we will likely do it as a research protocol very soon.
All right. We got a question here. Are ester oh sorry. Dr. V and Mr. T. Can metformin and or inositol help with egg quality even if you do not have PCOS?
Inositol is a good anti-inflammatory. So possibly metformin. I'm not aware of anything that says in non-PCO, non-endometriosis patients metformin is beneficial. However, if you do have endometriosis, it may be of some value to you. So for endo patients, yes. For PCO patients, definitely. But for everybody else, there's no evidence that that metformin would be beneficial. Inositol, I've never seen in unselected populations, but it is a good anti-inflammatory, so it probably would help.
Hi, doctors. After taking amoxicillin, can I start trying to get pregnant right away or do I need to wait? And how long should I wait?
You don't need to wait after taking amoxicillin. It's fine.
Easy peasy.
Easy
Hey,
peasy.
Dr. VNT. Is it best to wait and how long after being at possible risk of Zika risk countries like the Dominican Republic?
Oh, I haven't looked that up because Zika kind of died off, but it used to be 2 months for the men and, sorry, 2 months for the women and 6 months for the men. So I think we're still sticking with that to the best of my knowledge, but I honestly have not looked that up in forever. And you have to have signs that you had Zika. You have to have a flu-like illness. You have to have had a mosquito bite. So if you did, that's a different story. But in the absence of that, you're probably safe to go ahead.
I got a question here on TikTok.
Oh yeah, TikTok.
Uh, do you have any thoughts on the safety of finasteride while conceiving?
It's terrible for your sperm. We make our guys stop because it does have a very negative impact on sperm quality. So we tell guys that are on finasteride to stop for sure. I don't believe that there's any safety issues per se with the pregnancies that are conceived, but we definitely don't tell our guys to stay on it because it's hard to get pregnant when you're on finasteride.
How to get pregnant with PCOS?
Oh, well, it depends on which type of PCOS you are. If you're struggling with your body mass index, diet, weight loss, muscle building exercise, lots of natural supplements, letrozole, possibly metformin or one of the GLP-1s until your weight's in the category you want it to be in. Um, letrozole is the mainstay.
This question here hasn't been asked in a while, so I'm sure you'll appreciate it. What is your opinion on receptiva endometriosis tests?
It's useless, proven useless. No change in outcome based on the findings of a positive result in any of the studies that analyzed it. Now, granted, they weren't using our endo protocol, so it's hard to know, but I'm not a believer in that test. None of the tests like that have borne any fruit as far as being beneficial. So let me put it into the perfect context for you because it's in our endo video on YouTube, right? If you are doing Receptiva DX, according to their own website, it says it has a 96% sensitivity for detecting endometriosis, which actually sounds pretty damn impressive, right? Like, that's incredible. That's really, really good. So if you go to Nature, I think it's reports or Nature Science reports, and you look at a questionnaire online available for free that asks you 23 questions about your menstrual habits and your menstrual history and your pain symptoms and so on, it too has a 96% sensitivity. So save yourself the $750, fill out the 23 question questionnaire, and you'll know to the exact same degree if you have endo or not. Or just get a qualified physician that actually pays attention and looks at whether or not you have endo and then tells you yes or no and encourages you to go get it checked. I had a patient I spoke to today. Thank God she's pregnant. Hallelujah. Amen. I'm so happy for them. They struggled with their fertility. They live in a northern community and they weren't able to conceive. So then they went to a clinic. That clinic connected them with another clinic. As always, they shall remain nameless. And that clinic immediately said, "You've got unexplained infertility. You need IVF," which obviously isn't the case because there's 5 different things you can do for unexplained infertility now. But they told them they needed IVF. This was their best chance. Okay. So they then went and did a IVF protocol and they went through the IVF and they actually ended up not conceiving despite an embryo transfer. Well, they did, but then they had a miscarriage. And then they got pregnant on their own. And the question was, what's wrong? And clearly within minutes, she had already said, "I think I have endo." And I thought she had endo. And no one had ever said to her, "You should really just consider doing surgery." Like, why wouldn't you? Right? Before you jump into something like this and spend thousands of dollars, especially at a very expensive clinic, um, you should find out if you have endo because there's an 80% increase in success on your own naturally without needing us if you just clear out the endo. So why aren't we doing that? Because fertility centers want to do IVF. And why am I not doing that? Like, why do I tell people to actually go for your surgery? Because it's important to be honest and tell people the truth. The truth is, surgery should be part of the discussion of any patient that you suspect has endo, any patient with unexplained infertility. Remember, 44% of patients with unexplained infertility will have endometriosis, recent meta analysis. So if you have unexplained infertility, you have pain symptoms, sex is uncomfortable, your periods are painful, they're super heavy, you have deep pelvic pain, chronic pelvic pain, any sort of weird symptoms like that, or you have obvious things like a cyst of endo, don't just be ignored. Don't let them just gaslight you. Ask for why surgery isn't on the table. It should be every single time.
I had a MMC at 7 weeks.
Okay.
Doctor said likely due to genetics. What are the chances of that happening again this time? Husband's SA was good, but didn't do a DNA fragmentation.
Oh, I can't answer that. I need your age. I need your BMI. I need your habits. I need his DNA fragmentation. I mean, one miscarriage is not predictive of another, but more than 2 is predictive of a third miscarriage. So I can't tell you based on just one time. You'd have to give me way more details than that.
Hello, doctors.
That's the two of
That's
us.
the two
Yeah,
of us. Yeah,
I get
absolutely.
you feeling that, man.
Good feeling. Good feeling.
Why don't you just go to med school?
Why don't I go to med school?
You could. I mean, in theory, it's possible.
In theory,
Yeah.
but also probably
Yeah.
not possible.
Well,
Seems like a lot.
you know how old the oldest medical student in my class was?
I'm listening.
Take a guess.
Based on the way you introduced that question, 35.
45. Yeah.
Hope for everybody out there.
Yeah.
What is your Hashimoto's protocol using Synthroid and Letrozole already?
We typically will put people on inositol and selenium. If their antibodies are really high, you got to tweak their synthroid appropriately. And then we will add in steroids for the ones that are sky high just to try and calm it down a little bit. But I'll also send them to a naturopath. Honestly, they're way better at eliminating the autoimmunity than we are. And I have no shame in acknowledging that naturopaths are very useful teammates in our fertility care. There's a recent clinic that touted the fact that they had a new treatment available, which involved vitamins, and claimed that they were the first in Canada to do this. We'd already been doing it since the pandemic, so they weren't the first in Canada. I mean, I was doing it because I read an article that said vitamin C concentrations in the follicular fluid was important. And I talked to my naturopath. I said, how do we get this in there? She said, IV vitamins. So we started that program, I think in 2021 or 2022. So, yeah, I mean, we've been doing it for a long time. It's something we offer our patients, but you've got to be open to using the experts in that field, because we as fertility specialists got zero training on intrafollicular vitamin C concentrations. I only knew about it because I looked it up. So it's really important to say, hey, I know this much, and the naturopaths know this much in their field. And if you're tipping into their field, you definitely want to involve them, or traditional Chinese medicine or Ayurvedic or whatever you're looking at. So it's good to involve those people because they're the experts in their field.
I know this much.
Yeah, I the more I learn, the more I know nothing. That's why
That's the truth.
that's why I get angry with the, I can't say crazy people, but with the individuals on the posts who are so convinced that they know everything. Because I always say that the person that thinks they know everything and knows nothing is literally the most dangerous person in the world.
Absolutely.
Because they're oblivious to the fact that they don't know anything. They think they know it all, but they actually don't. And it was so funny to find John Cleese talking about that with that Dunning-Kruger effect, because it's so true. You actually need to be intelligent enough to know that you know nothing. And so the really smart people actually say, look, I don't know everything. And I'm not claiming I'm really smart, but I'm more than happy to admit I don't know everything.
I know even less than he does. So how smart am I? Take it that way. Do you take out of province consults, Alberta specifically?
Yeah, I'd say probably about 5 to 10% of our practice is from Alberta. I guess there's a lot of dissatisfaction there with the fertility care. So, yes, I do all the time. We are actually trying to get a spot in Alberta. So, that's one of the projects that we are working on. But yeah, by all means, we will happily consult with you in Alberta.
Do you take consults from the US? Another question.
All the time. Yeah. I mean, that's probably 20% of our practice. Did you see that Alberta's they're trying to start a referendum to secede?
I saw that.
Did
I
you
saw
see that?
I don't know if that's true. Is that actually true? Do you know if
Yeah.
that's true?
Yeah. They've got a petition out. And once they get, I think it's 600,000 people to sign, they get to vote on a referendum to secede. They want to become the 51st state, which would make Trump super happy because it's all that oil there, right? Like,
then the oil of Canada's got nothing after
and
that.
he splits Canada in half.
Well, that's the rich part of Canada.
Oh, that would be a disaster, man.
Yeah. Dr. V, have you heard of sperm QT? And what are your thoughts on it? Is it the same thing as anti-sperm antibody tests? And do you offer that? One more. Would a mini Lupron flare, 10 units starting on cycle day 2, then following with a regular injection from day 3, be helpful if antagonist protocols didn't work? Does this require priming?
I have heard of sperm QT, but I know nothing about it. So I'd have to look that one up for you. Microdose flare protocols, I actually loved. We just lost access to it in Canada because they stopped making Lupron in the format that we could use for microdose flare. So that's off the table now. But it was excellent, and we really liked it when we used it. And when I can get my hands on it, I do still use it. So it's a very reasonable protocol. I would strongly advise you to reach out to us to find out how you were primed before your cycle, because I find these days that with our priming methods, the microdose flare is no longer necessary. Between appropriate priming for patients, and appropriate's the key, and doing duostim cycles, you don't really need to get a microdose flare anymore. But I did love it, and I have no objections to it whatsoever. It's awesome.
Dr. V, what can we do to improve DNA frag? Thank you.
Oh, that's easy. Ejaculate every day or every other day nonstop. On the day that you need to use the sample, ejaculate once, and then 3 hours later, ejaculate again. Use the second sample. It's got 80% less DNA frag. No smoking, no drinking, no drugs. Healthy diet. If he's heavy, make him lose weight. And I don't mean 5 pounds, I mean like make him lose weight. Exercise, muscle building, healthy diet, low sugar, low cholesterol, low inflammation. Take fertility vitamins for men and keep the testicles cold. So, no cell phone in your pocket, no laptop on your lap, no car seat heater, no sauna, jacuzzi, hot tub, that kind of thing. Make sure you're sitting on frozen peas for a minimum of 20, preferably 30 minutes per day, and only feed them to your worst enemy.
That's what I feed to my worst enemy on a regular basis. Dr. V and T, would you treat an IVF patient with thyroid hormones when they are T4, T3 is normal, but TSH is above normal range? What TSH target do you aim for? And is there a lot of evidence to treat this?
There used to be evidence. Newer evidence is sort of contrary, but we still do it. So the target is less than 2.5 for your TSH. It would depend on where your T3 and your T4 were. If your T4 is 18 and your TSH is 2.8, I'm not going to treat it because you already have a high T4. And if I give you more, you're going to overdo it and be hyperthyroid. So that has to be individualized for each patient.
Dr. V, for IUI,
Yeah.
does multiple ejaculations provided by in one specimen increase the chances of conception?
Well, the timing for that is complicated because while we're waiting for you to redo it, unless you're Superman, you can do it really quickly. The other sample's already getting processed. Now, if you could do two in a row within like an hour of each other, yeah, of course, the more sperm, the better. There's no question. But if you're talking like hours apart, that probably wouldn't be helpful.
All right. Dr. V,
Yep.
I am in the IUI process. Does the clinic do the procedure on weekends?
This is the shocking thing I learned recently, and I knew it, but I'd forgotten it, and it came back to the fore. There is at least one clinic in Toronto which closes on weekends. They're not doing IVF.
Oh, wow.
And I don't know if they're doing IUI, but they're not doing IVF. So they just tell patients, you either got to retrieve Friday or you're waiting until Monday.
Wow.
Which we know either overcooks the eggs or undercooks
Time
them.
sensitive kind of thing here.
Very time sensitive thing. Yeah. So VRC is open every single day of the year without fail at all our locations. The only time that we are not open is when it is Christmas time and we actually close the lab in order to clean it. So we give everyone a break for a week at that point, but the rest of the year we are open, and we are actually still open for IUI over Christmas, just not for IVF.
Crazy.
Yeah, how do you do that?
How do you do that? I don't know.
I don't know.
That's, even I know
It's a
That's no good.
24/7 job. Yeah.
24/7
Like I
job.
don't get that at all.
Dr. V,
Yeah.
wondering your thoughts on turmeric supplements.
Yeah.
Do they have any benefits when trying to conceive with
Yeah.
endometriosis?
Huge. We recommend it as part of our routine 5 supplements for endo. So curcumin, which is the powder form of turmeric, has been shown to be beneficial as an anti-inflammatory in endo patients specifically. So we use it all the time. Yeah.
Belated Eid Mubarak, Dr. C and V.
Oh, very nice.
What dose? No. What does? I apologize. What does a non-endo, i.e., non-Lupron FET protocol look like at VRC? Of course, tailored to each patient. This is a good viewer here. They understand.
Yeah, our general approach would be Lupron cycle day 21, letrozole day 3 to 7, wait for the lining to thicken, minimal estrogen, if at all, and then double progesterone, lots of natural supplements, wait for the lining to hit 8 to 9 millimeters thickness, transfer the embryo.
Boom. Done deal. Hey, doctors, what if a person has positive ANA, no known autoimmune issues or symptoms, except for RIF with 4 transfers? Would you expect a different issue than immune?
Well, I would be asking why the only thing we know about you is just positive ANA. So I'd be looking at a fertility test, microbiome. You want to know about your immune testing, not just thrombophilia or autoimmune factors, but do you have elevated NK cells? Do you have high NK cytotoxicity, T regulatory cells, cytokines, and so on? In addition to that, I'd be looking very closely at the shape of your uterus and your partner's DNA fragmentation. So there's a lot of stuff that goes into it. Your vitamins, your thyroid, your body mass index, your habits. Are you smoking? Was he smoking? Like there's a lot of stuff that we pour into recurrent implantation failure, recurrent pregnancy loss, which allows us to solve the problem in so many patients that come to us.
Not sure about this question.
Okay.
Hello, Dr. V and Tariq, spelled with an IK.
Tariq.
Tariq.
That's okay.
We'll let it go.
I just got Dr. V. So, hey, man, they're not trying my full name. If anyone tried to spell Rahi, you'd probably get Rocky.
But victory's
most,
good. Victory's
yeah,
nice.
The most common thing people call me is Rocky when I introduce myself.
Really?
Yeah, I'll say, hi, I'm Rahi.
That's
and they
what they
go,
heard, eh?
Rocky? I'm like, no.
I usually actually just say, yeah. That's it. You got it, buddy.
It's real.
How do you assess oocyte quality?
My lab does. So they look for things like cytoplasmic granules, vacuoles, dark cytoplasm, the resistance of the shell of the egg to the penetration with the needle. They look for the dark center of the egg, whether it is or isn't. It's not good if it is. And they look for smooth endoplasmic reticulum aggregates. So there's a lot of different features that they look at.
Is it true you can naturally sway the gender of a baby?
No.
Wait.
But it doesn't matter.
There's still more.
Yeah.
No. This is good. This is good.
All right. Yeah.
I have an answer here.
Okay.
According to Google. Already the reference is strong.
Oh.
According to Google, male sperm are fast.
Yeah.
And female sperm are slow.
Yeah.
Therefore,
yeah.
If you do the deed 2 or 3 days before ovulation,
right,
can you have a girl and a boy on the day of ovulation? Any truth to that?
Zero. It's been tested. It's been trialed. That's all nonsense. You got to remember, like in an average decent sperm sample, there are millions of sperm. So, nothing is going to alter it. It's not like the male sperm are all fast and the female sperm are all slow. It doesn't work like that. Otherwise, we'd have the world full of males, and actually women outnumber men almost by 2 to 1 very soon. So no, it does not work like that. And I don't know what you got off of Google, but that was definitely not correct. That is not true. And there is absolutely no way to impact the gender of a baby. There are many people that claim that they can. It is absolutely not true. Nobody can impact the gender of a baby. Nobody.
I heard if you have chicken noodle soup, I can do it. Hi, doctors.
Yeah,
After 3 months lupron how many days of estrogen do you give before checking the lining for endometriosis patients?
we don't. We just let your lining thicken, and we only give you estrogen if your lining isn't thickening enough on its own within about 10 days. So we don't give you estrogen. You don't want to take all that suppression and then undo it. One of the patients I spoke to today did 3 months suppression of Lupron in case she had endo because the clinic wouldn't take her seriously, and then got a high dose estrogen protocol. Like, that's absurd. So even if you are going to take estrogen, you only take it if you need it, and then you only do it like a little bit, a very little bit, 1 milligram a day, 2 milligrams a day.
Hi, Dr. VNT. If I wean from BFing at 6, 9, and 12 millimeters or meters, 12
Months,
months. Yeah,
months.
yeah, yeah.
That's breastfeeding.
BFing, breastfeeding?
Breastfeeding.
Good thing you made that clear. I was really screaming, what is BFing? Who is B and who is effing was what I was wondering. But I guess it's all very clear now, isn't it? Anyway, good to know. Good to know. Very good information.
Breastfeeding, dude. Breastfeeding. Yeah.
That's right. I guess.
At what months?
Yeah, at 6, 9, or 12 months.
Yeah.
Should I do suppression for endo again before FET? And if so, how long?
No, because if you're breastfeeding, it's natural suppression. You don't need the endo suppression. I mean, unless you have really brutal endo, but otherwise you don't you don't need the suppression because you're naturally suppressed. Torque's making me laugh off.
The problem, of course, is the fact that I said that out loud. Like, it's out there, right? Anyway, it's 8:46.
Yeah.
Fertility After Dark.
It's
more than
fertility
okay.
after dark.
Yeah,
now. That's
the
right.
first 15 minutes, it's okay. After that, God help us. Prior to a C-section,
Yeah.
endometritis hysteroscopy scheduled.
Prior to a C-section?
Yeah, prior to a C-section. That's what it says.
Endometritis,
100%. Endometritis hysteroscopy scheduled. What should my doctor be looking for?
That makes no sense. That can't say prior to a C-section. You can't do a hysteroscopy while the patient's getting ready to deliver a baby. I don't know what
I just read them.
Yeah, I don't. That one makes no sense.
Sometimes I translate them incorrectly, but I just read them. Hello. Is a modified natural protocol still an option if I have irregular periods due to premenopause?
It can be. It depends on how well you respond. But yes, it's certainly worthy of trying. I would never tell you not to try. It's a reasonable thing to attempt. At worst, you're out a little bit of meds and time, but yeah, I would still try it.
I'm new here,
Welcome.
but I just want to check if your clinics do a back-to-back embryo banking.
I think we were the first in Canada to do duostem. I'm not sure about that, but I believe we were. So yes, we're happy to do back to back embryo banking. It's not a problem. I don't necessarily always recommend it because we do find you'll make more eggs if we split your cycles apart, do one follicular, and then in the next month do the luteal. But some people benefit from a back to back, and so we'll do that. Yeah, we have no trouble accommodating virtually any request from any patient.
How much estrogen after an FET do you recommend most clinics give it for 12 weeks?
If you're taking estrogen, which we try to avoid, you should stay on it, I think, for 12 weeks. But you don't need estrogen most of the time. But if you need it, I keep my patients on it till 12 weeks.
I have a referral for a histosalpingogram,
Yeah.
but I am booked for a hysterosonogram. Are they the same?
No. A hysterosonogram is done with ultrasound and provides you with way more information. And it is far more comfortable because it's fluid. It's not dye, which is an oil-based contrast. So it's way less viscous and it's much easier to flush through the tubes. The HSG is an X-ray done typically in a hospital, and it is typically much more uncomfortable. Now, it depends on the patient. Not every patient is uncomfortable from it, and not every physician makes it uncomfortable. So when I do them, I try and make them very, very comfortable for the patients, but it is still much more uncomfortable than an SIS is. Yeah.
Good evening. Thank you for your time. Please advise for women who would like to do their fertility in their late 40s, BMI 28, what is the chances of having twins in IUI?
Oh boy, low. I mean, at 40, the chances you're going to get pregnant are low, let alone the chances you're going to have twins. It would be dependent on the number of eggs that you produce. But let's say you're getting roughly a 10% chance per IUI. Even if you had multi-follicle development, you're probably looking at about 30% of those becoming twins, maybe maximum 40%. So, you're talking overall a 4% chance per try.
Does dermatology medications around genitalia affect the IUI/IVF success? Example, antifungal, scabies, or steroids?
Uh, I would be wondering why you're having sex if you have an active infection. So that does not make sense. And if you have anything like that, for the love of God, do not bring your sample into a fertility center because you're going to contaminate everything in sight. So please don't try while actively fighting off infections and using any kind of serious antifungal medication. That would be horrendous for the fertility center or your partner.
What are the benefits of adding the HCG shot after a natural LH surge and a non medicated stim? Cycle no letrozole for an IUI. Is there any data that confirms an increase in success rates?
Yeah, so this is a great question. So years and years ago, when we first started the show, there was a study that said that there is no benefit to the HCG trigger if you have a natural LH surge. Then there was a study that said there was, and then there was another one that said that there wasn't. So we trigger because there's a study from Hamilton, Ontario that said that even when you naturally surge, it's better when you do an LH trigger, and their results were double. So we still LH trigger even when the patient naturally surges. It's just to confirm that the patient's going to release. But I mean, the percentages are so small, guys. I don't really think that makes a big difference. But the data is quite sort of equivocal. One study says this, the next study says that, and then the next one said the first thing. So who knows?
Hey, Dr. V, advice do you have to increase your chance of getting pregnant with PCOS?
We did that one.
What chances of success with donor eggs is intended for parents with endo?
With our endo protocol, probably 75, 80%. We have a patient currently pregnant who had some of the absolute worst endo I've ever seen. We got her on donor eggs. She's doing great. So, yeah, I mean, we do a really good job with our endo protocol. So it almost normalizes people with endo, which is why it's gone worldwide. And I get calls from people all over the place. We had a patient calls from Bosnia, yeah, saying they heard about it and they wanted help. So it's a global phenomenon now, what we do. And yeah, so it's pretty cool. That was you and me, buddy. We did it, man. And the rest of the team.
Of course.
Yeah,
Can't take away from the
I can't
team.
ignore the rest of the team.
No. Team effort. Absolutely.
Team. Yeah.
Tracking BBT and CM. I am ovulating regularly, but specialist recommended Clomid. Will it help?
Cervical mucus and basal body temperature have been proven to be useless, so that's a waste of your time. Clomid will help you make more eggs, but I don't know what your diagnosis is, so that could be helpful or useless. Depends on what the diagnosis is for your infertility. But tracking cervical mucus and basal body temperature proven to be of no value whatsoever.
Just to clarify, not me, questioner.
Mm-hmm.
About the earlier question, if I do a mini Lupron flare,
Yeah.
do I still need estrogen priming, or can I jump straight into it?
Estrogen priming is useless, so you should never do estrogen priming. Don't bother with estrogen priming. It does not help you.
I have a euploid from IVM M1. Any concerns with embryo health transfer outcomes?
No.
Did you say metformin for endo patients?
Yes. So we had a review of that recently on the show where metformin actually is beneficial for patients with endometriosis. So we are integrating that into our endo protocol.
They followed up with, I'll be so skinny, I want it now.
Well, endo doesn't make you skinny, and in many cases, it doesn't really help people lose that much weight, but it does make you hella stomach sick. So it's not a pleasant thing to be on for sure. It's pretty rough on your tummy.
In your opinion, is there any relation between MTHFR genetic mutations and infertility RPL?
Yes, no question. We put all those patients on baby aspirin and on heparin, and they do better.
Hi, doctors.
Oh, you're loving that. Yeah.
I'm good with that.
Yeah. Yeah.
Can we talk about late embryo implantations? It's not talked about. What are the success rates?
I don't know what they mean. You mean like a day 7 embryo? Can you clarify that question for me? If it's a day 7 embryo you're asking about, 15% if it's euploid. The success rates are terrible. They're not good at all, unfortunately. So we don't really focus on our day 7s very much at all.
Why is ovarian tissue transplants not a thing for those struggling with low ovarian reserve?
If you mean an ovarian tissue transplant from somebody else, I mean, you would have graft versus host disease, and then you wouldn't be getting donor eggs. Sorry, you wouldn't be getting your own eggs. So why wouldn't we just do a donor egg cycle for you without needing to subject you to surgery? I'm not sure if that's what you're asking, but no one that I've ever heard of is doing ovarian tissue transplantation. There are people doing ovarian tissue cryopreservation. I did one of the first cases in Canada, but that is for patients, generally speaking, who have cancer and want to cryopreserve their ovarian tissue so that it doesn't get exposed to the chemo. Um, Most of the time, we're just freezing eggs. It's way easier. But if you have a time crunch, you can extract the tissue, like an ovary, and save the tissue.
Tracking BBT is useless. Can
Yes.
you elaborate?
Yeah, I mean, there's lots of studies showing tracking basal body temperature is useless and tracking cervical mucus is useless. It is not um, sensitive enough to help you detect your ovulation, and it drives everybody insane. Both the partners typically get very frustrated doing that, and satisfaction rates are generally very poor. An LH kit, ovulation kit, is way more predictive than your basal body temperature or your cervical mucus. Why would you bother with those? Pee on a stick, it tells you when you're ovulating. That's when you want to have sex that day and the next day, preferably the day before as well. But yeah, there's no value to doing BBT and CM, zero. And they've proven that in studies. We presented that on the show. There's a video on YouTube. It's a million years old now, but it's one of our videos there. It very clearly shows doing those things are useless. It gets all the natural people riled up, but it's totally useless. It doesn't help anything.
I want to ask something.
Okay, fire away.
No, that's all I got so far from them.
Oh, all right. Go ahead and ask.
Figure
Yeah.
if they wrote it, then I might as well ask it.
Yeah.
Okay.
2 minutes.
2 minutes. Uh, what do you think of NOA, early maturation arrest?
Non-obstructive azoospermia early match. I need more details.
All right.
The embryo arrested, the sperm arrested. I'm not sure what you're asking me.
Um, is it possible to get pregnant with low ejaculate volume?
Yes, you just need high sperm count, right? The volume isn't critical necessarily, although you need a minimum volume to be considered normal. But yeah, the ejaculate volume isn't critical; it's the count and the motility and the morphology.
Question phrased in a mysterious way.
Okay.
Um, hold on, as soon as this roll. 33,
Okay.
19 BMI, 2 euploid losses, all normal RPL tests, normal hysteroscopy. RE doesn't believe in RI.
Time for a new RE. So any RE that doesn't believe in RI isn't reading enough, because it's crystal clear that the immune system and the microbiome play a huge role. Whether you believe in the treatments or not is a different story. And I'm happy to debate anybody on that because I know the evidence. But there's no question that you can't say, I don't believe in RI. That's just ignorance. You can't do that. So come see us and we'll take care of you because there's clearly something wrong and they're missing it.
I have low AMH and thinking of adding testosterone as priming to my next cycle.
Yes.
Gel or injection?
No. Just gel. Don't inject.
What is your experience with the endometritis in the case of recurrent pregnancy loss?
Huge factor, enormous. And the data supports that completely. So there's tons of data on that now. And that's why we pay so much attention to the microbiome.
My AMH is very low and my age is 32. Any solution?
DHEA, testosterone priming, human growth hormone priming, maybe ovarian PRP. I'm not convinced by it, even though we do it, but I don't know if it works that well or not. It may be beneficial in the short term for a little bit. Those are the only things anybody's aware of at the moment. There is hope for the future. Someone is actually working on an AMH molecule that will be able to help you, but we don't have it yet. Yeah,
That was the inactivity
on
TikTok.
TikTok. Yeah.
A question related to probably what we were talking about. You and I were discussing subjects, what to do a video on. We showed this one, so I think they read this article as well.
Okay.
Thanks a lot, docs, for your efforts. How do you ensure that the clinic I'm with follows a stringent protocol to avoid mixing and misidentification of sperm?
Well, ask them for what their protocol is. How many people witness? How do they do it? What protocols are in place? What's their standard operating procedure? Who's overseeing it? All of that stuff. That's critical. We're overtime.
Overtime. Thank you for helping me. My little is now 5.
Oh, that's so cute. And a great way to end the show. Okay. Thank you all very much for joining us on our hour-long Fertility Factor Fiction, our journey through the week where we figure out how to make your fertility success better. Join us next week where we will have endo fertility nutrition. And we will have the following week Juniper Genomics talking about whole genome sequencing. For those of you that have had multiple failures, multiple miscarriages, those who have failed even with a surrogate, these are the answers you're looking for. Let's find out exactly what nutrition is great for endo patients and how we make things better for them. Love to see you guys all next week. Hope you have a wonderful week in the meantime. Stay safe and stay fertile.